imagine and hope that we'll have questions. Then when that is done, we've exhausted our questions, then for the panel, we will then turn to Mr. Daniel for his presentation. If I've said anything or misspoken, Executive Director, let me know. But I wanted to navigate us through that before we got started. So without any further ado, I will defer to Dr. Strickland, Michael Strickland, who's waiting in the wings to come up, one of our very fine research associates. Dr. Strickland, I'm going to recognize you and ask you to introduce our panelists and take charge of this presentation. Dr. Strickland, thank you.
Thank you, sir. And good morning, Commissioners. My name is Michael Strickland, and today we will be hearing from a panel on the subject of reference-based pricing in healthcare. The cost of healthcare is a persistent concern for many, both nationally and in Tennessee, and medical bills for a given procedure can vary dramatically, sometimes by orders of magnitude. And the costs of insurance premiums, deductibles, and debt can all weigh heavily on individuals' finances. Reference-based pricing is one method for trying to control the cost of healthcare that has gained some attention in recent years. Very simply, reference-based pricing places a limit on the prices of healthcare services, with that limit indexed to a reference point. Most often, this is taken in the form of limiting medical costs to some ratio of Medicare rates.
Excuse me, Dr. Strickland. Everyone up here can hear you fine but me. Could you just speak up or speak a little closer to the mic? Senator Lundberg.
Mr. Chairman, I noticed some feedback, I think, by the phone. Mr. Daniel could mute his phone until we begin his presentation.
Is it Mr. Weber right now? Yes, yes, please do that. If you could mute your phone, Mr. Weber. And I'm really sorry to interrupt you in a very important presentation, but I just couldn't hear you.
No. To date, 7 states have acted to adopt reference-based pricing in some form. In 4 states, California, Montana, North Carolina, and Oregon, it has been applied only to state employee health plans. One state, Washington, in what it refers to as a public option, has applied it to selected health insurance plans for individuals that are then administered by commercial insurance providers. And 2 other states, Colorado and Nevada, have made plans to do the same in the coming years. In some cases, the reference price is a limit on what the insurer will agree to pay medical providers for their services. Medical providers may then choose to bill patients for any remaining bill balance above the reference price that the insurer agrees to pay, and this is known as balance billing. In other cases, the medical provider contractually agrees not to charge more than the reference price for a service, so that balance billing of patients does not arise. Senate Bill 2330 by Senator Hensley and House Bill 2468 by Representative Sparks directed the Commission to study the overall effect on health insurance prices when reference-based pricing is used. A draft report will be presented at the December 2022 Commission meeting, and the final report will be presented at the January 2023 meeting. Today, the Commission will hear from 4 panelists about reference-based pricing: Representative Mike Sparks, Lori Lee, Executive Director of Benefits Administration, Tennessee Department of Finance and Administration; Randy Stamps, former Executive Director, Tennessee State Employees Association; and Ralph Weber, President and CEO of Medibid, who could not travel to be here in person today, but is joining by phone. After that, we will hear from former Representative Martin Daniel, owner and general manager of Elevation Outdoor Advertising, who has asked to make a statement regarding the Attorney General's State Employee Health Care Plan Claims Audit. A written analysis and summary of his observations about the audit are included in this tab.
Thank you, Dr. Strickland. It's good to see all the panelists that we know all very well. And Chairman has asked that we limit our comments to 10 minutes, and I don't think that'll be a problem. And we will begin as listed with Representative Sparks. Representative?
Thank you, members. Members, I believe in what TACIR does. You know, sometimes what's frustrating as a lawmaker is maybe we don't dig down into issues, especially in cost savings and transparency. And that's what I'm attempting to do here with this dialogue. I've got a sister in a nursing home, a mother, been in a nursing home. We're taking care of her now. And I'm experiencing this in my personal life, like many of y'all have experienced it with parents and grandparents. And it just seems like there's a lot of lack of transparency. a lot of lack of unknowns when it comes to healthcare. But I'd called Ralph Weber. I knew Ralph from Rutherford County and didn't know Ralph that well. And I just said, Ralph, what could be done about healthcare? And he says, Mike, and he brought up reference-based pricing. Didn't know much about reference-based pricing. So started studying it. We started asking for a few records, and I think what this has revealed is a lot of outliers when it comes to the costs that the state has paid out. Even Proverbs talks about before you build a tower, you want to study your cost. And I think it's vital to being a representative to study our costs with the health care plan. We've got a good health care plan. Some would argue maybe it's an expensive health care plan. So if this attempt is to save money like Montana has went with, my understanding Montana, and I know Montana's not a good comparable state such as Georgia or Alabama would be for Tennessee, but Montana saved $14 million. They have about 1 million people, a little over 1 million people. We're at roughly, $6.8 million. If it saved them 14 million, hopefully that would save us close to 100 million, maybe 96 million. I think the records we've been asking for and the study and the dialogue the past 3 years has, one, led to an audit that I think Martin Daniel is going to discuss, and maybe Mr. Weber may get into it as well. Want to share, let me back up. On the TACIR, one reason I believe in y'all is took on an issue about 3 years ago that was really uncomfortable. I don't know how many of y'all were on that panel at the time, but it was about childhood sexual trauma, something that no one really wants to discuss, to be honest. I didn't want to discuss it until a gentleman kept coming to me about it. It's hard to run a bill to try to address that. So what I did, I asked for a TACIR study, and I want to compliment Dr. Cliff Lippard with that. And that ultimately led to legislation. So that's why I believe in the leveraging TACIR, leveraging your bright minds to study these issues, to dig down deep that are serious issues. Just like childhood trauma is a serious issue that leads to adverse implications, whether it's addiction, alcoholism, and other areas, this $1.6 billion healthcare plan and this dialogue, I think, can help maybe raise some questions that y'all can ask. Why do we have these outliers? Why are we paying this much in outliers? I like what someone told me the other day. He said, there's two kinds of money. It's yours and mine. If I'm having to write that check for a car, for a TV, for a couch, or remodeling a house that I'm remodeling, I'm going to study those costs. I'm going to dig down deep. I'm going to look around. If I'm using your money, I'm probably not going to dig down as deep. And I think we all know that. So that's what I bring this for, and I appreciate Mr. Weber and Mr. Daniel and others that are very interested in reference-based pricing and what other states have done. So thank you for your time.
Thank you, Mr. Chairman. My name is Laurie Lee. I'm Executive Director of Benefits Administration. Thank you for the opportunity first to address the Commission and for the work of TACIR on this topic. First, just a little bit of background information on who we are. Benefits Administration is a division of the Department of Finance and Administration, and we administer the benefits directed by the state, local education, and local government insurance committees, which are set up in statute, through 3 separate self-funded risk pools or plans known collectively as the State Group Insurance Program. We offer health insurance coverage through the state plan for about 100 state agencies, higher education entities, through the local education plan for about 120 local education agencies, and through the local government plan for about 400 local government agencies and quasi-governmental entities. We cover about 287,000 people in every county across the state and retirees throughout the country with this program. We wear 2 hats, I like to say. One is that we manage the employee benefits for the state as an employer, state and higher education, and then we manage the health plan options for participating local agencies, both education and local government. We're the largest purchaser of employer-based health care in the state, and we leverage that purchasing power, our buying power of the 3 plans through collective procurement that's competitively procured, through benefit design and management of contracts, including contracting with best-in-class providers to secure best price and expertise. Unlike TennCare, I like to say that because these are two very different plans, so it's important to distinguish, but unlike TennCare, we do not pay a premium to an MCO or an insurance company. The state is the insurer, essentially. We collect premiums from employers, employees, retirees to pay the cost of our members' health care directly. And the premiums that we collect and expenditures are managed through dedicated funds in the state. So again, we're not paying a premium to insurers. We have our own funds, dedicated funds, to pay out claims. Instead of a premium, like other large self-insured employers, we pay a flat fee to use contractors' networks and other administrative services. And so the contractors, again, are third-party administrators. They're not insurers for us. So that's a brief overview of who we are. I want to turn to reference-based pricing, which is the topic today. Reference-based pricing is one type of cost containment tool for health plans designed to increase patients' use of low-price facilities or sites, reduce the use of high-price facilities or sites, and generate cost savings for the purchasers of care. That's employers or insurers, not always for the patients. The term reference-based pricing has become a catch-all for a variety of healthcare pricing processes. And Mr. Strickland did a good job, I think, of describing sort of that framework. But that's one framework. There are a lot of different variations on that theme. Some versions reference a price benchmark, such as Medicare. Some reference an average or a percent of what providers are getting paid, or a budget to which plan participants must adhere to. And there are variations on this concept as well. For example, reference-based benefits, such as setting a maximum allowed benefit to plan participants. Think of an elective procedure such as a total hip or knee arthroscopy and a maximum benefit for those very specific procedures. There's also reference-based contracting, which anchors a provider contract to a reference, such as Medicare or some other reference point. And then there's reference-based pricing. And this is a little bit different, more of a vendor-convened model that also anchors the provider price to Medicare or another benchmark, but without a formal provider contract. And that's an important distinction here, because the contract is important because the patient or member is not as protected from balance billing, for example, if the provider has not contracted to the reference price. There are multiple vendors who offer a vendor-convened model like this. There's several out in the marketplace. I think we're going to hear from one today. So I'm going to just acknowledge that we're well aware of the rising cost of healthcare. It's our #1 strategic issue. We continually research best practices through professional organizations, trainings, evaluation tools, case study reviews, and healthcare business groups to identify what's going to be the best practice and fit given the structure of our plan and the requirements of our members. I'd like to share a perspective on this topic that may seem a very obvious point, and that is the total cost of anything is the function of two things: the price of that thing and the number of units that you're purchasing. So in healthcare, we would call the units utilization. So the total cost in healthcare is the price of the service times the utilization of the service. Reference-based pricing deals with one side of that equation, and that is price. Our focus in benefits administration is on the total cost of care and the total value of care, which, in addition to price, brings in dimensions such as outcomes for what you're purchasing, quality, efficiency, and member supports, all of which help address utilization, which is the other side of the equation. So price and utilization. Reference-based pricing is one piece of that. So let's look at price first. According to the analysis conducted by our contracted actuarial consultant, in 2021, our plan's total combined payment rate was 157% of Medicare. I want to rest with that number for a minute because I'm going to come back to that. Compare that experience and results with Montana that we just heard about. Montana was the first state to adopt a reference price for its employee health plans. And before the reference-based pricing agreements, Montana paid a range of 191 to 322% of Medicare rates for inpatient services and 239 to 611% of Medicare rates for hospital outpatient. After implementing their reference-based pricing, Montana's provider agreements lowered the range to 220 to 225% for inpatient services and 230 to 250% for outpatient services. That's Montana's experience with reference-based pricing. So they were starting from a very high reference point and brought it down, producing the savings that we heard referenced. So there are clearly results in savings for Montana, but our average today, again, is 157% of Medicare. It's less than where Montana ended up after they implemented reference-based pricing. So how are we doing this in Tennessee with our plans? Here's some of the strategies that we're using. We're procuring best price through efficient networks. We procure 2 medical TPAs right now, that is Cigna and Blue Cross Blue Shield. Again, we procure these competitively through a competitive bid, and each have an efficient or lower cost network option with savings to both the plan and our members. Some states have implemented reference-based pricing strategies, and Montana is a good example of this, don't have the kind of competition that we have in Tennessee. So they might have a single large administrator, and pretty much everybody's in the network. So there's not the ability to have the kind of efficiencies when you have competition and the ability to have different network options. The other thing we're doing is we're focused on offering initiatives that prioritize total value. Again, high quality, low cost, best outcomes. So examples of this include a bone and joint program that is offered by one of our carriers. Our substance use preferred facility network is another example. Again, focusing not just on price is a piece of that, but also on outcomes. We are aware that price variation is real and exists, and the reference to outliers is very real, and we are aware of that. One aim of reference-based pricing is to reduce this variation with a limit on price. There may be good reasons for price variation. For example, some variation can be explained by complexity of case that might require an inpatient setting versus an outpatient setting, or rural and urban locations, which might generate a difference in price for the very same thing. I think providers and carriers could better address the variation in pricing because we're not engaged in that price negotiation directly. To the extent that these negotiations result in efficient networks, however, with best aggregate pricing, well, we are interested in that. And our combined percent of Medicare at 150% reflects that. So while there may be individual outliers in pricing, in the aggregate, our procurement and network strategy to get best price and value is working. We continue to evaluate programs and effectiveness to determine appropriate mix of benefit design to best serve our members. And getting best price in the aggregate is one part of our strategy, for sure. But addressing price alone does not totally address rising costs, as utilization is the other part of that equation. So in addition to value-based clinical programs, such as the 2 I just referenced, we also offer services to address utilization, such as price transparency tools through our vendors, disease management programs, our wellness program, and second opinion services that engage employees in healthcare choices. Some of the challenges and considerations that we think of with reference-based pricing I want to share with you. Does not necessarily consider the quality of providers in the equation, as the reference price does not help direct patients to higher quality providers. So you may encourage the use of a provider with the lowest price, but poor outcomes may result in complications. So if the patient ends up getting readmitted into a hospital, say, or coming back for additional care on the outpatient side, is that best price? You might be paying 1.5 times. Is that in the best interest of our members? Setting strict pricing caps could result in provider network erosion with possible issues of access to care. Some providers may refuse to provide services for reference-based price members, which can be problematic in geographic areas with limited access to care. And we do have that issue across the state in some areas. From a member perspective, reference-based pricing models can put members at risk for balanced billing or being turned away from care. Providers may accept payment from the RBP price vendor, but generate a balanced bill to the member for the difference. Some models are very confusing to members. Patients may be unaware that they may be subject to additional costs, making them financially vulnerable. And there's complexity then of member communication, education, how to support members with some of these programs that we've identified through some of our literature review. A shopping for care, a bidding model for services may not be practical. For example, a bid might result in a provider in Idaho for a colonoscopy. Confession here, I've had a few colonoscopies. And if you have, you know you don't personally want to be in a hotel when you're doing colonoscopy prep before a procedure. I'd rather be at home, not in a hotel in Boise. There may be some compliance issues. The Affordable Care Act has some specific requirements around reasonable access to care and quality standards. There are several lawsuits that we're aware of that are currently working their way through the courts related to reference-based pricing, mostly by providers against administrators and employer plans. In summary, there are various models of reference-based pricing. Its impact depends on which model is adopted, and some models are very broad, some are very narrow and focused. You cannot assume that what worked in one place will work everywhere. A good example is that the broad brush approach implemented in Montana has not been successful in North Carolina. Healthcare market dynamics vary significantly across the country, and what is acceptable in one place may be a non-starter in another market.
Ms. Lee, if you could make your conclusion.
2 more points. Yes, sir. As with most purported solutions, it's important to understand first what problem you're trying to solve. And with an aggregate price of 150% of Medicare, in our plan, setting a reference-based price at 250% of Medicare or close, like what Montana did, would actually set us back and cost us more. And if you set it below what we're getting right now, you run the risk of network erosion. So just to close, Mr. Chairman, we continue to focus on total cost of care, on total value, balancing best price with outcomes and with member access, member protections, and quality. Thank you.
Thank you, Ms. Lee. And I believe next is Randy Stamps, who's the former executive director of the Tennessee State Employees Association.
Thank you, Mr. Chairman. My name is Randy Stamps, and I'm a retiree member of the Tennessee State Employees Association. And I want to thank you for the opportunity to share some thoughts with you today. First of all, I want to thank Governor Lee and the legislature for maintaining a health system for our state employees that is outstanding. State employees also appreciate that the state of Tennessee pays 80% of the insurance premium costs for our active state employees. TSEA understands that both private and governmental employers are always searching for opportunities to save on health care costs. Reference-based pricing is one method to control health care costs, but it is clearly not the only means to control health care costs. Tennessee has been working at saving on health care costs for many years. In recent years, state-provided insurance coverage has been eliminated for those retiring before age 65, if those employees were hired after July 1st of 2015. This change will continue to save our state insurance plans significant dollars. Also, retirees have been placed in a separate category to ensure that premium costs of active employees are not negatively impacted by retiree premium costs as they were just a few years ago. Adjustments have also been made to ensure that those that elect individual insurance plans or are not eligible for family insurance coverage do not pay higher premium costs because of those who do have family medical coverage. Family medical coverage premiums are now adjusted separately from those utilizing individual covers. Most recently, a majority of the State Insurance Committee voted to increase the out-of-pocket cost of insurance plan members, and this reduced the premium cost to the state of Tennessee. Out-of-pocket costs are already used to help plan members consider the most effective method to utilize health care needs. A prime example is that current out-of-pocket expenses are greater if a plan member chooses an emergency room visit instead of an urgent care visit. I talk about all of these measures because it demonstrates that state employees and TSEA have been partners in all of these changes, or at least partners in explaining the need for these changes to our state employees. Please understand that TSEA has not adopted a position on reference-based pricing. Once TACIR presents its final report in January, it is highly likely TSEA will follow our internal procedures and take a position on reference-based pricing. During some previous legislative consideration of reference-based pricing and balance billing, some interest groups have implied that TSEA had a particular position on those issues, but that is simply not the case. During my 8 years on staff at TSEA, I have always found that Benefits and Administration Division of the State Finance Department has always provided us with information that is balanced, fair, transparent, and we use that to make those decisions that we must make. I would therefore expect TSEA to strongly consider any input received from Benefits and Administration as strongly as any other source of opinions or information. It's been referenced already that we are a very diverse state. We stretch many miles from West Tennessee to Northeast Tennessee. We already have some challenges with our current system when it comes to making sure, just as an example, that folks in Northeast Tennessee have the same opportunities for providers. I believe this proposed method could make that even worse than it is today. So that's a strong consideration. I think we all know, I believe folks from all across the state are represented here. There's a big difference between what goes on often in the providers available in West Tennessee than there are in Northeast Tennessee. One significant consideration would be if reference-based pricing is adopted for state employees, would it be tied to some assurance that out-of-pocket costs to state employees would be capped for a different period of time? The logic here is it would be limiting the health care choices of state employees with a stated justification of cost savings. State employees should therefore have some confidence that those savings would directly benefit state employees. Again, TSEA has not yet adopted a formal position on reference-based pricing, but I can speculate that given the current political mindset in Tennessee to treat state employees more and more like private sector employees, it seems unlikely that our association would support separating out state employees from this type of plan, as has been done in California, Montana, North Carolina, and Oregon. Again, I thank you for allowing TSA to participate today, and I appreciate always when we're allowed to be a part of the process, Mr. Chairman.
And thank you, Mr. Stams. And next, we have Mr. Ralph Weber, who is the president and CEO of Medibid. I believe he's going to speak to us by telephone. Is that correct? And I'll look to Dr. Strickland for the technology here to connect him in, or is he already connected? Can he speak to us now? I can't hear him.
I'm sorry, can you hear me, Mr. Chairman?
Not well at all.
Okay, I'm speaking right into the microphone. I will allow you to adjust the volume until I can hear it, and just let me know if I'm coming through clearly. Hello, can you hear me?
That's something better, yes. Let's try this and see, because we were almost inaudible.
I'm on the phone. I have a headset with a microphone right next to my mouth, speaking in a clear voice. Hopefully the volume can be adjusted so that you can hear me. Just let me know if I'm coming through clearly. I can speak a little bit louder if that helps.
I can hear now. Can anybody else have any problems hearing? I think we're good now.
Okay, great. Thank you, Chairman Yeager, members of the committee. I am coming to this committee by invitation of Mike Sparks, Representative Mike Sparks. As you mentioned, he called me several years ago, and he was interested in methods to save the state taxpayers money. My background, my expertise, I have been an employee benefits consultant for over 27 years. I have over 150 employer groups ranging in size from 50 members to 320,000. A large number of these groups employ reference-based pricing. So I have experience both in reference-based pricing and in the network model. Let's examine some of the facts. Right now, 100 million U.S. adults have healthcare debt. Healthcare costs are rising, and if 100 million U.S. adults, I'm sure many of the state employees carry healthcare debts, which is very, very unfortunate. 2/3, 66.5% of bankruptcies in the U.S. were caused by medical debt. As Lori Lee pointed out, she said that the current spending is 150% of Medicare. The data that Lori sent me regarding the 2018 spending was 150 exactly. The interesting point was that the data she sent me indicated that the in-network providers were paid 151% of Medicare, while the out-of-network providers only charged 145% of of Medicare, a difference of 6%. So if you apply that 6% to the total healthcare spending, which I have different numbers. I have $2.7 billion per year, and I have $1.6 billion per year. If you apply the out-of-network prices of 145% of Medicare, the 6% savings times $1.6 billion is $96 million a year in savings. If you use it by the billed charge of $2.7 billion, that would be $160 million per year in savings. So that is fairly significant. I do have a memo, an email from Blue Cross Blue Shield that says they do not give discounts to state employees through their providers, which this data from Lori Lee would back up. The price that the in-network providers are 6% more expensive than out-of-network providers. What we do know, and just to highlight just a few small procedures, we studied many, many, many procedures, but we had one provider charge $19,800 for a CT scan when the average price was $635. Now, Lori spoke about variance in pricing, and yes, there is going to be variance in pricing. A training hospital like Vanderbilt that's associated with the medical school is going to charge more because they have interns that they're training. I understand that. But the difference between $635 for an average and $19,800 is 3,100% variance. That, to me, is huge. And it's not just one provider. Colonoscopy, the average price was $1,212 in 2018, the average charged, and the one provider charged $17,341, a variance of 1,600%. And again, it wasn't just one provider. In that particular procedure, colonoscopy, Medicare measures quality of the provider on a 1 to 5 star basis, 5 star being the best. And Medicare is a very credible source in measuring quality. They take many things into account. It's not just patient reviews. It's actual mortality, morbidity, outcomes, et cetera. What we found is that most of the providers that were charging less than $5,000 were rated 4 to 5 stars by Medicare, while the ones that were charging over $10,000 were rated 2 to 3 stars. And if I had the ability to show the video of those findings, I would be happy to do that. So often, what we have found is the less that is charged, the better the quality. That can also be explained very easily by the fact that a more experienced doctor will do a surgery or an operation in shorter time, which results in less nights in the hospital, less time in the operating room, so therefore lower costs. Now, it's interesting to note that TennCare pays probably approximately 86% of Medicare, and there's no shortage of providers for TennCare. Medicare pays 100% of Medicare. Currently, the state, as Lori Lee said, in 2022 paid 157%. In 2018, it was 150%. So it's crept up a little bit, even though the Medicare rates have crept up as well. But using those out-of-network providers, instead of penalizing them and making employees pay more out-of-pocket costs, and again, this contributes to medical debt, it contributes to medical bankruptcies, by making employees pay more when the provider actually charges less. There's only one person that can control the cost of health care, and that's not the president, it's not the governor, it's the patient. The patient, as Mike said, is the best person to be able to control costs. The best way to get them to control costs is give them an incentive and transparency and some shopping tools to motivate them to pick a good quality provider. Now, Lori Lee mentioned going to Boise, Idaho for colonoscopy, and I'm not sure who would want to do that. There are many, many, many providers in Tennessee, many very good providers. Colonoscopies in Tennessee, interestingly enough, Tennessee is one of the lowest states. We talk about shopping for medical care across state lines. In some states, a colonoscopy must be done under general anesthesia in an inpatient facility, which would increase the cost. In the state of Tennessee, it could be done under sedative in a doctor's office, reducing the cost. So going to Boise, Idaho, would actually probably increase the costs on a colonoscopy. Low-cost providers is, I don't like that term. I think in a fair market, every provider should be able to set their costs, not have them set by an insurance company. I also think that gouging by charging $19,800 for a CT scan or $17,341 for a colonoscopy should also be capped. If the state sent an employee on a business trip and they stayed in the Ritz-Carlton and had lobster thermidor for dinner, I'm sure the state wouldn't pay for that. Why is the state paying $17,341 for colonoscopy? Now, it might be argued that was what was charged, but I do have a memo from Blue Cross saying there is no discount, so I have to assume that that was what was paid. There is no formal provider contract in reference-based pricing, as Lori Lee pointed out, and that is correct. However, the one thing that hasn't been mentioned is the No Surprises Act, which passed in December of 2020, which started being implemented July 1 of this year and continues to be implemented January 23 and July of 2023. The No Surprises Act, and I'm sure that many people have had the unfortunate experience of going to a hospital and having an out-of-network anesthesiologist or provider of any sort balance bill. There has been no protection against that. The No Surprises Act states that out-of-network providers cannot balance bill the employee. It's much more complex than that. I'm oversimplifying, but that actually makes reference-based pricing a much more consumer-friendly tool. The other thing about reference-based pricing is it gives the employees the transparency up front, and given the shopping tools, they can make an effective choice. They don't need to be told by the insurance company which doctor to go to and which doctor not to go to. In regards to quality and outcomes, those need to be shown in advance as well, so that the employee can make an effective choice. Lori Lee spoke about efficient networks. I don't think a network that costs $100 to $160 million a year is efficient. That would not be my definition of efficient, because I consider the cost as well. And I don't think that any out-of-network provider is automatically low quality because they're not in network. They are charging less, and many of them are the same, if not better quality. The variation in pricing, again, there were not just individual outliers. I would be happy to show the data that we studied to show there were many, 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 many providers charging 200%, 300%, up to 3,000% more than the average, okay? And those expenses, what reference-based pricing does is it draws a line and it says this is the maximum the state will reimburse. With an average of 150%, we've all heard the expression that you can drown in a lake that's an average depth of 3 inches, because that means it might have a low end of 100 feet. So the average is not a good measurement. And with a lack of transparency, we can't tell what the average is. And as Representative Sparks pointed out, we're not spending our own money when we're consuming health care. We're spending somebody else's, so we don't have the same due diligence. We've had clients, we've had companies with 200 employees that in 2017 were spending $2.1 million a year on health care. Today, this year, 2022, they'll spend $750 million. We have a company of 500 missionaries in North Carolina that we're going to be spending $6 million this year with a big insurance company. We reduced their cost to $4.5 million, still with a big insurance company, but allowing them more choices.
Mr. Weber, if you would,
reference-based
Mr.
pricing
Weber,
could be a choice. It doesn't
Mr.
have
Weber.
to be something that everybody has to participate in.
Mr. Weber,
So, I'm sorry.
excuse me, if you could bring
Yes.
it to a conclusion.
Okay, sure. Yes, absolutely. The last thing I wanted to address is one thing that Randy Stamps mentioned. As I referenced in the beginning, the large number of people with medical debt, I'm sure that state employees are not immune to that percentage. Can out-of-pocket be capped? Absolutely. The amount of money that the state would be paying, there could absolutely be a way to write the plan so that it caps the maximum out-of-pocket expenses at a lower amount now to help to prevent medical bankruptcies. Mr. Chairman?
Thank you very much. I appreciate your informative report. Now, before we go to questions from the members for the panelists, since Ms. Lee's name and Mr. Stamp's names were mentioned, I'll give you an opportunity for comment, further comment, brief comment. Ms. Lee and then Mr. Stamps.
Thank you, Mr.
you
Chairman. Thank you, Mr. Chairman. I do want to just make sure I explain and sort of correct for the record. When Mr. Weber talks about the data shared in 2018, those data were billed charges. There's a big difference between billed charges and net pay. Now, he references a memo from Blue Cross about no discounts. That is what the networks do, is and what the carriers do is negotiate prices with providers off of billed charges. So if you get an explanation of benefits, you go to a provider and you see EOB, you'll see what was charged and what the discount was. That is the network discount that the carriers are providing through their negotiations with the providers. So the data that Mr. Weber is referencing was billed charge data because we could not release the net pay data publicly. So it's that first billed charge public information before the network discounts are applied. So I just wanted to correct that. There are transparency tools more and more online with our contracted carriers. So to Mr. Weber's point about being able to provide information to members to understand price before for those elective procedures before they engage. That's really a good news. So I think the potential savings that are referenced again, when you look at what we're currently paying, I think the potential to go much below that you start eroding access access standards for our members. So, what we're balancing is access as well as price, and I think we've met a good balance there. Those were the couple of things that I wanted to make sure I addressed. So thank you, Mr. Chairman, for that opportunity.
Mr. Stamps.
The only thing I'd like to say, Mr. Chairman, is that I'm glad to hear that the gentleman that testified does believe that we could cap out-of-pocket costs. And again, I believe TSCA's position would be that if you're going to limit the availability of health care and the providers that are available to state employees, they should see some direct benefit by limiting out-of-pocket costs. Thank you.
I think Mr. Sparks wants to comment, and your name was mentioned too, so.
Yes, sir. Just want to mention, I thought it's ironic. I appreciate the great job that Randy's done for the state employees for years. I had a state employee recently, someone that every one of y'all, I believe, probably knows. It was in my office back around April. We got talking about health care. He said, I got a bill today for $2,400. He said, and I thought, what is this? He said, I was about to go ahead and put it on my credit card. And he says, I started digging, didn't know $2,400. So he was charged this. So the point I want to make is appreciate Randy from the State Employee Association speaking on that, because I had a state employee that had a problem. So I think this goes to show that we need more dialogue on health care, whether it's our constituents that are facing bankruptcy with high health care cost. I wrote an op-ed called Cattywampus with Vanderbilt economist and healthcare professional Dr. Van Horn last year. So I think we all know we got a problem. So I just appreciate y'all's indulgence, and I hope we keep this going, Chairman. Thank you.
Thank you, Mr. Sparks. And we will now take questions from the members for the panelists. And I think Representative Parkinson has asked for the floor.
Thank you, Mr. Chair. To my colleague, good to see you. Right. And to anyone that may want to answer this question, is there anything that we have in policy, law, or anywhere else that would make the providers show the range of cost next to what they are charging our members?
So the transparency tools on the provider website, if you're in our plan, if you're a Blue Cross member or a Cigna member, you can go online and see what you're going to pay. So that would be the negotiated rate. I'm just trying to envision whether that also shows their billed charges or not, and I'm not sure if it shows that side by side. But the purpose of that tool is to help members understand what they would actually pay, what their payment would be.
Thank you for that. And so I'm wondering if a possible solution would be for us to have the providers put a range of costs next to what they're charging the individuals for these services. So, say for instance, if that cost was $2,400 to the state employee, then maybe they should have in a separate column next to that, possibly say this is what the range of cost for that is. And if $2,400 is at the far end of that, they should be ashamed of themselves, And if 200 is the bottom end of it, we got a problem, right? But that transparency, maybe that's a solution that would create the competition that's needed in order to get those prices down. Thank you, Mr. Chair.
You're welcome. Senator Campbell.
Thank you, Mr. Chair. Ms. Lee, you referenced North Carolina as not having great outcomes. Can you just give me briefly some perspective on why that was the case?
So as I understand it, and this may still be an ongoing, and Dr. Strickland might be able to speak to this a little bit better because they've dug into more broadly what's been happening. But so the initiative that Montana had, which was with the state employee programs to implement reference pricing, described that. My understanding in North Carolina, which actually the North Carolina market is a lot more like ours than Montana. both in terms of rural and urban, and the players in the market, and the provider makeup is much different than Montana. So as I understand it, the issues were really around, could you get providers in a network that agreed to the reference price? And this is why I was referring to network erosion, and you can start to diminish the choices available to members.
Are there other questions? Yes, Mayor.
Thank you. I had one comment that kind of goes back to Mr. Sparks. I know that not long ago, it was just a routine physical that I got an exorbitant bill on, and it took hours and hours of looking into it to come to find out that whoever had coded it to a different procedure that I had not had at all. So how many people, though, just don't want to go through that? They don't want to question it for whatever reason and end up paying a bill that's not theirs. The other thing, what exactly determines, and I know it's probably a complex process, but just an overview of who's in network and who's not?
Is that from?
For whoever can answer it.
Thank you. I'll talk about our plan. So, we contract with the carriers through a competitive process, and part of what we're asking them to do in our contracts is to establish the networks. So, the carriers are the ones that then negotiate with the providers the pricing, and then who's in and who's out. And as I mentioned, what we do is we contract with two different carriers, and each carrier offers two networks. One is a very broad network, which costs more because there are more providers in that network. And then they each offer a narrow network that's more efficient. And so we do get significant discounts on that narrow network. And that's really a process that the carriers do undertake with the providers to set up that network. And that's that provider negotiation piece that I said we don't do, but through our contract, that the carriers are our agents in setting those up.
Thank you.
Thanks, Chairman. And Mayor Holland brought back to my recollection something that I needed to share on behalf of a former legislator and COVID survivor. I spent 11 days in the hospital, and like some of my colleagues, received bills. The one that was the most surprising, I was on oxygen for 11 days, and they sent me home with oxygen, and Blue Cross Blue Shield decided they would not cover oxygen. And it was your team, Ms. Lee, that reached out and contacted them on my behalf, and miraculously, the life-saving and life-giving oxygen that I was carrying around with me for another 2 weeks was miraculously covered. But it was thousands of dollars. It wasn't minimal. But to Mayor Holland's point, it was a coding issue. And I wanted to just take a moment to say your team did a great job on the benefit side as a former state employee, as Randy. So thank you.
Thank you.
Councilman Carlisle.
Thank you. Mayor Brooks, I'm glad you're still with us. A harrowing experience, no doubt. Our firm has roughly 6,800 employees with about 1,200 open positions, like many probably people in private practice. So if anybody's got anybody looking for a job, please send them my way. We switched to RBO, or RBP rather, sometime in 2014, 2015, so I'm pretty familiar with it. And I think always the balance for an employer is that benefits coordinator explaining a very complex and complicated process to people that are not, their touch point is that only when they need it, right? Typically it's like, hey, I'm gonna go get my annual physical. That's pretty, hopefully I get to keep my doctor. It's when a reference or a referred surgery and or consultant with a cardiologist or a pulmonologist comes along. And that's, I think, starts to begin the complicating factor for some consumers or some of your, I would say, customers or clients, is, so-and-so doctor is the recommended doctor, but they're not in a contract or a network. And so now there's a decision to be made between somebody that may be considered in their field better than the others, and that always is can be problematic that we run into. The question I think I've got, well, then of course you've got the competitive environment, right? Like, so the state still has to compete, and I was actually talking yesterday with Speaker Sexton's chief of staff just about how the TBI handles their forensic analyst in the West Tennessee Forensic. We've got many open positions. Rape kits have obviously hit national attention based on what's happened in Memphis, Tennessee, and just talking about how they're competing with forensic analysts with the private market. And we run into the same thing at the city of Memphis, right? You've got people that are highly trained professional services, and then the private sector starts coming to call. And so benefits are a way that we can compete against private sectors that are profit driven. And so I really do understand that balance. And there's so much more information I would love to get from you, just because this is a subject that I think is fascinating and I don't know nearly enough about. How do you measure, you use the term outcome, right, in the grand scheme of things. How is that measured? And you gave a really good example about, well, the quality of care may have been cheaper, but because the quality was poor, they had to go back in 2 or 3 times for follow-up, so we know the outcome, the value wasn't there. So at a high level, how do you measure outcome?
That's a great question. And so I'll let me just use one of the examples, the substance use disorder network. What we found in looking at our data was that some of the very, very high-cost providers were out of network, and members were choosing to go out of network, and they had the worst outcomes. So how did we define outcomes? So in the substance use world, it wouldn't be complications, but it would be folks that are having to be readmitted within, a month of discharge. So they go through a treatment, for a month, and then, within the next, 2 months, they're back in. So that kind of revolving door. Now, on the medical side, medical surgical side, it could be complications that does that as well. So that's one of the things that we look at is readmissions due to complications. On the substance use side, it would be, folks that come back, in a period of time that would be considered, well, this is an early readmission. So, of course, you also look at mortality and morbidity statistics. Mr. Weber mentioned a good point, which is some providers that do the most volume are the lower cost because the processes are well refined and defined. Open heart surgery is a great example. You don't want to go to a surgeon who does this, once or twice a year. So you do have some correlation there between positive outcomes, mortality, morbidity, with volume, and often does result in lower price. So, but in terms of outcomes, what we're really looking at is the patient getting better, and so mortality, morbidity, readmissions. Those are some typical examples.
Yes.
One more. Yeah, continue. One more. We have 2 people waiting for the floor.
Thank you, Mr. Chairman. Well, if that's the case, then I'll yield the floor.
Thank you very much. Representative Williams and then Chairman Hazelwood.
Thank you. Ms. Lee, I guess the discussion about, unfortunately, I had the opportunity to sit through Health Committee where we talked about outcome-based formulas for TACIR, but in that system of outcome-based formularies, we were determining what reimbursement people were going to get. It's my understanding based upon this that that's not the case. Outcomes aren't actually driving the rate, or am I mishearing there? So, for instance, if somebody went to substance abuse and counseling or treatment, and they're getting paid based upon whatever the rate is then based upon our benefits, but if they do get readmitted, it's my understanding we're not sending them a bill for 10% back based upon their outcomes formula, are we?
So a couple of things there. We don't set the rates, and we don't get involved in any of the rate setting at all. Which I can't speak to TennCare's process, but again, we're structured very differently. So So that rate-setting decision happens through the carriers. That's one of the things that we're contracting with them to do. And so the joint program that I referenced, one of the factors that carrier is looking at is what is the sort of overall performance and outcomes of a certain practice in doing total joints, knees and hips, for example. So that is factored into their rate negotiation with the providers.
So,
one more.
So there is no ability for the state or by way of the employee through a joint replacement where they had a bad outcome, and there's no way to penalize or financially impact the situation after the fact, I guess is what I'm saying.
Mm-hmm. I can't speak to the, there may be some provider carrier negotiations that might have some aspects in their contract that say, if someone is readmitted within 30 days, we don't pay for that readmission. So, there are ways to do that contractually. But I'm probably not the best person to speak to how that gets built into the contracted price and the negotiations with the providers.
Thank you.
Chairman Hazelwood, you're recognized.
A couple of comments and then a question. I'd like to hear more about I have a real concern about the erosion of networks that you mentioned. From other work that we do in this body, I think we all know that we have a healthcare shortage in the state. We don't have enough doctors, particularly in our rural areas, and there are certain specialties of doctors that are try and get into a gastroenterologist or a particular specialty anywhere in the state, and it's going to be months unless you have an urgent situation and are able to get moved to the head of the line. So, when we start, and I think what we're talking about, this maybe I am oversimplifying, but this seems to me we're talking about squeezing provider pricing. When you do that, you are going to discourage those providers from being a part of your network and providing services, and then you're going to be forced to go somewhere for a much higher cost. So that is a really concern, and I think somebody mentioned it's two kinds of money, my money and your money, and we look at them differently. I think there are two kind of bodies here too. If it's my body or my family's body and I'm searching for health care, then I'm going to be much more about the quality and the outcome than the cost. And so I think, as you mentioned, Ms. Lee, that there's going to be, there has to be a balancing of those pricing, but we also have to look at quality and outcomes. And I know again, in someone's presentation, they mentioned that the Balanced Billing Act and that's effective. But what I've heard about that there's just an incredible amount of arbitration going on, and that the cases are stacked up, and they were months behind already, and this just was implemented. So the Balanced Billing Act, again, I have concerns. The cost is the cost. We can shift it different ways, but what I don't want us to do is shift it from the back of one entity to another. I also have concerns about third party who would be, frankly, taking a piece of the healthcare cost and utilizing it to help us. So again, could you just kind of delve a little bit deeper into the network and whatever, are we having difficulties already with providers and network and what this might do to that? Thank you.
Thank you for that question. That is exactly what we're trying to balance here. And I did want to take issue with the comment that, or the implication that we're not as concerned about somebody else's money, because we are, in Benefits Administration, we are very concerned about that. We take that responsibility in terms of safeguarding taxpayer money very, very seriously. It's taxpayer money. It's our money as members. My team works very hard to ensure the fiscal integrity of our plan. So I did want to put that on the record because I really object to that characterization. So that is exactly what we're trying to balance there. As you referenced, Chair Lady, we're in a position right now where it's not getting better in terms of provider availability, and in some specialty areas. You mentioned one, but in some geographic areas in the state, it's across the board. We have severe problems with behavioral health providers that are. There's such a shortage that many are not in network because there's such a shortage of providers. So that is one of the things that we're trying to balance. I think it was Mr. Weber that referenced that TennCares pays 86.86. So 86% of Medicare. If Medicare is 100, they're paying below. And of course, we're paying higher. It's not unusual. I won't say this is right, but it's not unusual for commercial purchasers, businesses to pick up, to pay more. But again, the fact that we're at 157% of Medicare is I think is striking the right balance. So to your question about what our observation is. We are concerned about erosion of networks. We do have providers, come in and out often, more than we used to see. And so again, that's when I talk about the carriers negotiating on our behalf, they are taking into consideration issues such as, do we have a shortage in a particular area? And intuitively, you might think, oh, well, we're paying more for urban providers, right? Because the cost of living is so much higher in urban areas. That's not always the case. Sometimes as a result of those negotiations and having a full network or an adequate network, we might pay more in a rural area because of the shortage. So there's that just that market dynamic going on in provider negotiations and provider payment. And I think if we squeeze the balloon too hard, it's gonna come out somewhere else in terms of access and primarily access, but also quality as well.
Thank you. Are there any other questions for the panel? We still have one speaker left. We will let Mayor Frank bring the curtain down on the questions unless there's objection. Mayor?
Just a quick question for Ms. Lee. Mr. Weber mentioned a couple of really eye-opening examples of outliers. If you don't like the reference-based or you've got concerns about it, I shouldn't use the word don't like, but what would be your solution? Or do you see those as just cost of doing business, or do you have another idea for how that could be addressed? Because it is something that connects with the average person as being a problem.
Yes, absolutely. I can address that. The Medicare rate, what Medicare pays, actually varies from hospital to hospital, and it's based on their cost of doing business. As I mentioned earlier, Vanderbilt is a teaching hospital, so they would get paid more for the same procedure as another hospital does because their costs are higher. They have to train young doctors, interns, et cetera. And rural hospitals get paid different as well. Medicare every year does a lengthy survey of every hospital, and they have to report on all of their costs, all of their outcomes, and that's how they set the rates. So 150% of Medicare, for example, is roughly 50% more than their cost because the Medicare rates are supposed to be very close to the cost of actually providing the services. Lori Lee mentioned the narrow network. And anybody that doesn't stay in the narrow network has the out-of-network deductible, which is twice as high, the coinsurance, which is greater. So that actually is the limiting network access more than reference-based pricing. Reference-based pricing will pay any provider not only in the state of Tennessee, but even outside of the state. If somebody chooses to go to Boise for a colonoscopy, you know, as Lori Lee mentioned, that some people might like to do, they can do that if they want to. But it pays any provider whatever, again, generally speaking, their cost of doing business plus 50%, whereas a narrow network says if you go outside of this network, you're going to have to pay more out-of-pocket costs, even though the providers charge 6% less. So you are, in essence, being penalized for going to a more cost-effective provider who might have as good or better outcomes. The other thing is, Lori Lee mentioned that we were looking at bill charge, and that's correct. But to get $19,800 down to the average of $635, even a 90% discount brings it up down to $1,900. So how much of a discount would they have to give to get down to the average? It would be ridiculously high, 95, 98, percent. Maybe Dr. Strickland can crunch the numbers, but I find it difficult to believe that some providers are giving in excess of a 90% discount, and if that's the case, why not be transparent? The transparency tools that the carriers provide only provide transparency in that narrow network. So you don't see people outside of the network that might be more cost effective. So again, having a narrow network is really what erodes the network more so than reference-based pricing, which opens the playing field. The other thing is when you only allow a few providers to participate in a pool, you are eliminating competition. By eliminating competition, anybody that has any economic or business background knows that eliminating competition increases the prices. And again, this is referenced by the fact that in-network providers are 6% more expensive because they have, in essence, a monopoly on the state employees, and everybody else is excluded because employees are penalized by higher out-of-pocket costs for going to them.
If you could draw it to a conclusion, Mr. Weber.
I'm sorry?
If you could draw it to a conclusion.
I'm sorry. No, I was just addressing the question.
I understand that, but we have someone waiting to speak to the.
Okay, sorry. I'm sorry.
No, don't be. Appreciate it. So, with that comment, thank you very much. We now have Mr. Daniel to speak to us. I think we take just a moment here. We have to disconnect this call, and then reach Mr. Daniel on this, if I'm correct there. So, just take a moment.
Michael? Commission, can you hear me?
Yes, we can hear you.
Hello, I'm here.
We can hear you.
Good morning, Commission. Can you hear me okay?
Can all of you hear? Ladies and gentlemen, we have now making the last presentation on this issue for us this morning would be former Representative Martin Daniel, who is the owner and general manager of Elevation Outdoor Advertising. Representative Daniel, you are recognized, sir.
Thank you, Chairman Yeager, and good morning, Commission. It's a pleasure to be with you this morning. I appreciate you allowing me to present by way of telephone call this morning. And just by way of disclosure, I want to make the committee aware that I am a member and enrollee of the state health care plan, as are my children, my two dependent children, and my wife, a 32-year employee of the state health care plan, is also an enrollee of the plan. And I'll just get right to my presentation. I know your time is short, but the state of Tennessee, like many large U.S. employers, who provide health insurance, health benefits to their employees is at a disadvantage because of limited insight into charges and network discounts for healthcare services. For example, I encourage anyone on the commission to request basic information relating to the administration of the state's healthcare plan. Notwithstanding that fact, that this is an information owned and generated by the state's plan, that requester is likely to soon be facing lawsuits from plan administrators claiming that such information is confidential and proprietary and seeking an order preventing disclosure of that data. Transparency in healthcare costs is certainly inadequate. Furthermore, I ask that the Commission note that the healthcare market in Tennessee is far from a purely competitive market. Firms and persons seeking to offer significant healthcare services must often seek government permission to invest capital, hire staff, and set up shop. Permission given by way of this highly lawyerized and highly politicized process is called a certificate of need. Thus, the healthcare provider market in Tennessee is more like an oligopoly than a free market enterprise, and the natural economic forces of supply and demand cannot function to efficiently provide services at the lowest possible price. I ask that you note that as to the competitive aspect of healthcare, or lack thereof, there is no significant mechanism or procedure currently in place whereby enrollees of Tennessee healthcare plan are encouraged to actually seek out the lowest healthcare provider. And by the way, numerous surveys and studies have shown that there is little, if any, correlation between cost in healthcare and quality of healthcare. Finally, Commission, there is evidence that healthcare costs incurred and paid by the Tennessee plans are excessive. As you've heard the testimony of Mr. Weber, there are many reasons for this, but there's clear evidence that as recently as 2018, widely varying amounts were paid by the state healthcare plan for similar uncomplicated procedures. For example, data examiner reveals that in 2018, our arthroscopy procedure, that is removal of cartilage in the knee using an endoscope, was billed to the state of Tennessee at amounts ranging between $881 and $49,343. That's $49,343. Now, typically, amounts are paid at about 60% of the bills. But assuming that the median billed cost of an arthroscopy is $6,471, the state could see substantial cost savings by implementing a reference-based pricing model that limits payments to an established benchmark. This benchmark could be the average cost of procedures or the Medicare rate for procedures plus a reasonable profit percentage. In 2018, had payments for arthroscopies been limited to median billed amounts, the state would have realized savings of $540,000 on this procedure alone. How about colonoscopies? You heard Mr. Weber talk about that. This procedure is identified by CPT code 45380. These procedures were billed to our state at prices ranging from $300 to $1,828. That's $300 on the low end, $18,828 on the upper end. Even assuming a median billed cost of $3,128, the state would have saved over $927,000 in 2018. The payments have been limited to the median number. Finally, Commission, I ask that you consider this recent finding by the RAND Corporation. In 2020, U.S. self-funded employees paid on average of 224% of what Medicare pays those very same hospitals in full satisfaction of their health care bills. In Tennessee, self-funded employers, including our state health care plan, paid an average of more than 430% of what Medicare pays the same hospitals in satisfaction of their health care bills. let me restate that. The average pay by Medicare, the average paid by U.S. self-funded employees in 2020 was 224% of what Medicare pays. Tennessee, on the other hand, paid 430% of what Medicare pays. There was some discussion about Montana. What does it pay? It paid 166% of what Medicare paid to hospitals in 2020. Members of the committee, in summary, is with these considerations in mind, the inadequacy of transparency, the lack of competition, and the evidence of widely varying amounts being paid in Tennessee for similar healthcare procedures, that we ask that you consider reference-based pricing. Thank you.
Thank you, Representative Daniel. We appreciate those remarks. We will now allow the members to ask Representative Daniel any questions that you may have. There being none, we thank you very much for the presentation this morning. And Dr. Strickland, thank you very much for putting the panel together. This has been a very informative program this morning, panel, and we will certainly give great consideration to the comments today. So with that comment, then I will call the members' attention to tab 8 on tangible personal property tax in Tennessee. Michael Mount, our research director, is going to present the draft report for our review today and comment. You're recognized, sir.
Thank you, Chairman. Commissioners, my name is Michael Mount, and I'll be presenting the Commission's draft report on personal property tax for your review and comment. The draft was prepared in response to a request by Senator Lundberg at the January 2022 Commission meeting that the Commission study the personal property tax in Tennessee to examine the cost of businesses, both large and small, to report and pay the tax, their levels of compliance and tax payment, how much the tax contributed to overall revenue basis of local governments, large and small, as well as cost to those governments to collect on delinquent taxes, and possible revenue replacement models to be used if the tax were reduced or eliminated. At the June 2022 meeting, the Commission heard from a panel of 6 experts, and since then the Commission has identified 4 alternatives to make compliance easier for taxpayers and tax preparers and local governments without reducing local revenue. Tennessee currently gives about 13% of businesses an option to streamline the process of complying with the personal property tax. On the assessment form, a business can forego itemizing their property if they can certify, subject to audit, that they have $1,000 or less in personal property. To give more businesses a means to reduce the time and cost of filing personal property taxes without decreasing local tax revenue, the draft report has a recommendation that the General Assembly consider adding 1 or more tiers at greater dollar amounts. About 2/3 of Tennessee's counties continue to rely on paper filings, while only 1/3 offer e-filing. To encourage increased compliance with the tax, streamline the reporting process for businesses, reduce labor costs for assessors, encourage consistency in the filing requirements across jurisdictions, and to modernize the filing process. The draft recommends that the county assessors consider adopting e-filing and that they continue to be encouraged to do so. Some new businesses may incorrectly assume that the Department of Revenue administer all state and local taxes in Tennessee, and the information on state websites regarding personal property taxes could be easy to overlook. To better inform taxpayers of their tax obligations and to enhance compliance, the draft recommends that new businesses receive an email upon registration of the business that outlines all of the taxes that they might owe, including local taxes. In 1997, the Standard Industrial Classification System was replaced with the North America Industrial Classification System, or NAICS. However, Tennessee's business tax continues to use the SIC, while personal property taxes use the NAICS. To ensure that the business tax records across different government databases are consistent and updated, the Commission, the draft recommends that the General Assembly amend state law and update the industrial classifications used for the business tax from the Standard Industrial Classification, or SIC, to the North American Industry Classification System, or NAICS. And with that, I'd be happy to answer any questions.
Do you have any questions for Senator Lumber?
Thank you, Mr. Chairman. Thank you for the report. A couple I consider kind of low-hanging fruit, but help me dig into one, and what you just talked about, the Standard Industrial Classification. What is the SIC versus the NAICS, and how would that truly impact what is or is not being paid?
First off, the business tax, the rate that you paid is based on your business classification. So as part of filing the tax, you would need to identify the type of business that you have, and that would in turn determine the tax rate and what you pay. The business tax is related to the personal property tax because businesses may claim a credit against their business tax up to 50% of the personal property tax paid, up to 50% of their business tax paid against their, sorry, I said that wrong. Anyway, the difficulty is if you were ever to compare the comptroller's data on personal property, it would be in the NAICS code, and it wouldn't help you at all to confirm, or I shouldn't say it wouldn't help you at all. It wouldn't match the data in the business tax data as it is now.
So, candidly, we're just not comparing apples to apples.
Right, and it's more a matter that it just hadn't been updated since 1997.
If I may, I'm just going to continue, Chairman. Appreciate the idea, especially for smaller business, of that de minimis tax. There's a lot of information about the constitutionality and the things that we went through with personal property, and obviously the Supreme Court even said that it was unconstitutional for us to say this has no value. I'm asking you a judicial question. Would creating a threshold of $10,000 be constitutional?
Our sense is that it would be, because that is an assessment, it's subject to audit, and you would need to, your actual personal property value must be less than that threshold. So in a sense, you're paying more than you could have paid if you itemized the tax. However, we have heard from some who, like you said, do question the constitutionality of it. So it remains somewhat of a gray area, I suppose.
An unfair judiciary question, but the constitutionality is an important part of your report. There's a lot in the report about the revenue counties and cities derive from the tax. Is there somewhere where we can understand the cost to taxpayers to administer the tax on these jurisdictions?
From the taxpayer point of view?
Well, to the tax collector, and I know it varies from locality to locality. But what would be the average cost, and what would be the total administration relative to the nearly $500 million in tax assessed annually?
We surveyed the assessors, all 95 across the state, and summarized that on page 16 in Table 2. And what they told us was that the administrative costs were less than 1%. We also divided it large versus small population counties in response to the study request to make that distinction. But you can see that information there on table 2. It's doesn't seem especially burdensome as it is, I guess was the big takeaway.
All right. Thank you, Mr. Chairman and in committee. I guess it's also fundamentally just for me wearing a business hat. If I bought, and the state purchased this iPad, I did not, but if my company bought this iPad, we would pay taxes and sales tax on that when we purchased it. And then every year I'm going to continue to pay tax on that. And that is double, triple taxation. I have talked to some businesses that say, you know, at the end of some of their equipment, they're actually paying more in this tax than they are in that initial sales tax to purchase it. And I guess I inherently and philosophically have an issue with that. Thank you, Mr. Chairman.
You're welcome. And Representative Crawford?
Thank you, Mr. Chairman. In your suggestions here, you was talking about sending out an email, letting businesses know of their obligation in that. Whose responsibility would that be? Would that fall back to the assessors, or who would send that out?
We imagine that it could be some sort of collaboration either between the Department of Revenue, the Comptroller's Office, or local assessors, what they would want that to say.
So more than likely, it would fall back to some organization within the state and not be a burden on the locals, correct?
Yeah, unless they wanted to provide some input.
Okay, thank you.
Questions? Senator Yarborough.
Thank you, Mr. Chairman. One of the recommendations involves trying to figure out how to encourage the transition to electronic filing and submission here. I'm curious whether there are ways for counties to be part of the same system. Can you just talk a little bit about that?
Sure. The Comptroller's Office has a system already that's available to county assessors if they choose to use it. Like I said, though, about 2/3 have chosen not to at this point. It's this is described in our draft, but the system's only been around for a few years, so we imagine that a few more will adopt it as the years go by. But because it's voluntary, many have not so far.
Are there other questions? Yes, ma'am. Madam Clerk?
Yes, so there, to kind of explain a little bit about business tax, you've got 3 levels. So your first level is going to be anything up to $3,000. You can actually file an affidavit that you're anticipating your sales is going to be less than $3,000. You would not be required to have a business license. So the next tier is a minimal activity license. This goes back to the Small Business Tax Act that the legislature put in place. So if you anticipate your sales are going to be $10,000 or less, you can file a minimal activity license. And I do agree with Senator Lundberg that if you had a threshold of $10,000, then, and if it's constitutional that you're able to do this, that would be your small business owners would not be double and triple taxation on small items. So that $10,000 threshold would be a great, in my opinion, a great point to where you can, if you're a small business, you've got less than $10,000, you're going to file your minimal activity license through the county. You do not file that through the state. You file anything over $10,000 would be a standard business license. That is filed with the Department of Revenue. Now, the minimal activity license is sent over to the state because at some point in time, they anticipate their sales being more than $10,000. They're going to do an amendment and change to a standard business license. So at that point, they could start paying the personal property tax. So that may be something that we would want to look into and see if we can do the threshold up to $10,000. That would help the small business owners. And but yeah, those are 3 different tiers for business license.
Thank you very much. Are there other comments or questions? There being none, then thank you very much. Did you- okay. Let's see, item of other business, Director Lippert, is there other business for us to consider?
Mr. Chairman, there is not. The only other items are setting the next planning dates, and we've gotten into the habit of polling the members on that rather than trying to figure it out on the fly here. We do give two suggested dates in early and mid-December, but April will be reaching out to you to see what the preference of the commission is on that next meeting date.
All right. And we appreciate that. Is there anything else a member wishes to bring to the commission before we adjourn? Mayor?
I would, going back to yesterday and the water recreation resources, if it would be possible in December to have an update on the task force that they talked about yesterday, that would be great, just so we could see if that's progressing and
Yes.
how. Thank
The
you.
director says it's possible, and so thank you.
Great, thank you.
No problem. Any other? Well, there being none, we will stand in adjournment. Yes, you may.
Sit in adjournment.